My name is Megan Black. I am with Maryville University, and this is my professional interview. I am interviewing Terry Tucker. She's a nurse practitioner for our local state health department, and this is Terry.
Hello.
So I'm just going to kind of go down the list with the questions. Have you been a nurse practitioner for at least 1 year?
Yes.
How long have you been a nurse practitioner?
Since 2006.
Okay. And give me kind of a personal history.
Okay. Like how far back? You mean nursing career?
Yeah,
stuff?
nursing.
Okay. Well, first I wanted to be a pharmacist, and then I changed my mind because my dad's been a pharmacist for 40 years, and then he said, I think that you're more of a people person, knew nothing about nursing, ended up in the nursing program at Ada, and graduated in 1998 with my BSN and RN, and started with the State Department working with Children First, first-time pregnant moms in the home. Did that for about 4 years and was just really seeing just a disparity out in the community, saying that we just don't have very many providers. And I knew a little bit about nursing practitioners, but not a whole lot, and I had a lot of family that's doctors, and they all were wanting me to go to med school, and I changed my mind. So ended up applying for the OU program up at the University of Oklahoma at Oklahoma City, and was accepted in 2001 and started in 2002 and graduated in 2006. And so that was why I went, because being an RN was wonderful and awesome, but just being out in the community and seeing just around here the rural care.
You could make a difference.
Yeah.
Okay.
Yeah. At that time, I thought I could save the world. I remember that's what on my interview, they're like, that's what I said. I was like, I'm going to save my whole county, whatever.
Let's see. So tell me about your type of practice now.
Okay, I do 3 different things, and I've done that from the time I've started as an NP, and I think I'm just addicted to I get tired of the same thing, so I like a variety. I've worked urgent care and family practice, a little bit of cosmetic things, and I do urgent care and hospice and work with the state right now.
Okay. Let's see. Oh, it asked for the date of the interview. Today's September 8th, I believe, a Monday, 2014. And let's see. How did you find yourself in your present job? I guess let's go with your main one.
Okay. With the State Department of Oklahoma, I had already been a nurse with them for a while, and seeing with the benefits and everything like that is why I chose to stay with them, and they offered me a really good position there, and I cover 3 different clinics, and I've stayed there because of the stability of the job. And and I do women's health primarily, do pap smears, breast exams, head-to-toe physicals, refer a lot of people for breast cancer screening and things like that. And then I work in McCurtain, Cushman-Tahoe, and Choctaw County. So I have about 8,000 patients right now, client base.
Do you remember them when you see them?
Yeah, some of them. Yeah, not many. But I'm averaging about 2,500 per county, something like that. So it's a big population. It's a lot of people to serve, but I like it. I really like it.
It asks, what did you do to market yourself?
Well, I didn't know anything about how to do that when I graduated, because they really did not teach you that at OU. They just were like, it's kind of like where you want to go and where you live. Well, here, living in McCurtain County, there's not a lot of options. And so I first just checked around. I was offered a position with Choctaw Nation. They knew that I was looking for a position, but it was a commute to Hugo. When I went on my very first official interview, I had no idea how to negotiate a salary or anything like that, so I started calling around friends that had graduated and kind of seeing what the market was. and I highballed it because I had no idea, and I got it, and I was like, oh my gosh, because I just highballed what they told me, and then I asked for more.
And they just went for
And
it.
I got it, and I was like, shoot, I should have asked for more. But that's how I didn't know how to do it, because that was something I felt like was lacking in our schooling, was how to actually market yourself. Now in the city, it would be something that would be easy to go out and kind of have options, but here in the rural town, you don't really have a lot of options. And so it was hard to find a job. I felt like it was when I got out.
And it had asked, how do you negotiate salary and benefits? So, if I was going to go for my first interview, how should I go about that? What would you suggest?
Well, I just recently got that new job down in Sulphur Springs at the urgent care clinic, and what I did was kind of research how much NPs were getting hourly rates, and high would be about where I would negotiate it. Okay, how long I had been a nurse practitioner, because you have to do that, and then your experience and how needed you are in that area. You know, do they have 5 people interviewing for it, or is it just you? And how flexible you're going to be on scheduling and things like that. I would say that's one of the things they're going to look at most, is your experience, your willingness to be flexible on scheduling, and benefit package. You know, do you want a bonus when you first start to get you off the ground because you're transitioning from one job to another? Are you going to get insurance? Are you not? And if you're not, you know, how are they going to compensate you for that loss that you're going to have to, you know, make up for that? So, you know, I would always if you're very marketable right now. You're going to be very, very needed. When you graduate, there's going to be people looking for nurse practitioners more than they are in MDs and DOs, because
because it's so cost effective now.
It is very cost effective, and they only have to have one. Like, say they're going to be the clinical director, and hopefully in a year or two we're going to be full authority. So we won't need any kind of collaboration at all. That's another thing. If you're negotiating with a physician's office, you have to ask, see if they're going to need so much kickback from your visits and stuff like that, because they have to cover you, as far as being your collaborator. I don't have to worry about that because I'm contract. Everywhere I go, I'm a contractor. I'm not a sole proprietor. I'm not working for a small office. I'm working for big, groups that have more than one provider in it. So I've never had to worry about that, but I know some of my friends do.
What do you typically do for like malpractice, insurance, that kind of thing?
Right now, I carry a $1 million per claim and 600,000 trailer, and so I do that wherever I go. And it's I had to list like every clinic that I was at, but I carry that, and it costs about $1,800 a year.
That's not that bad.
No, it's not at all. They're real competitive, and you could. I think even for like a $2 million, it was only like $2,200 a year. But I carry that.
I do have a question that's not on here, just kind of out of curiosity. I've noticed, like, right now we have to have a supervising physician, and they're charging gobs of money for nurse practitioners, about $15,000 a year. Have you seen that? A lot? That they want that much if you go out on your own?
Yes. That's what I was about to say, because I know that the doctor I work under in Sulphur Springs, I think he gets $10,000 a year and they have to negotiate that per provider that's there. And there's me and another girl. So
wow.
Yeah.
Let's see. Describe your typical day, patients, and average number of patients daily.
Okay. At the health department, it's a patient every 20 minutes that's an annual head-to-toe physical. We charge that's how we get the level of visit that we're going to do. But it's on my main roster, it's one every 20 minutes with a problem visit scheduled 30-minute intervals in between. So a typical morning could be 9 head-to-toe physicals and 4 problem visits.
Okay.
So, yeah. unless if I'm doing clinic solo, because sometimes that happens.
So where do you have time to chart?
In between, you just like while the nurse is working it up, you get the chart, and it's much worse in urgent care. That is a lot more controlled environment when you know what's coming in, but it's urgent care. You could see 60 people a day, and you just go in there and you just head down, type it, e-script everything, and it's nuts. I like it though. See, but I like that kind of pace, so it doesn't bother me. But some people don't like it.
Let's see, it says, describe the setting in which you work, which you kind of already did that.
Mm-hmm.
How do you fit in the organizational structure, I guess? I guess a good example would be there at the health department.
Okay. My supervisor is our district nurse manager, who is over about 5 different counties, and then I answer directly to her. At the clinic there's no one really over me. It's our administrator first, and he's over all the same counties as our district nurse manager, then district nurse manager, then me.
Okay.
And then my nurses are under me. And our coordinating nurse takes care of the fires that happen between the RNs and stuff. And so I don't really have to answer to anybody there, but I do. My district nurse manager and my administrator, that's who signs my time.
Okay.
Yeah.
And how are you evaluated?
We have a performance evaluation every year, and mid-year we have any updates that they make us do. They'll come down and do our mid-year update, but most of the time we do our goals, and it's about a 3-page document, and we have to meet our goals, and you either get satisfactory, unsatisfactory. You shouldn't ever get unsatisfactory. You always have to get meets or exceeds standards. But every year we are evaluated on that, at least once a year, and then they make us, right now they're starting like community service projects and stuff too, and that's going to be a big part for the nurse practitioner to do, and they just started doing that.
What do you have in mind for that?
Well, we've already done, we did that health fair at the hospital with y'all, and we're supposed to try to start something new though, like the Great American Smokeout or something like that. We're right now
something to raise awareness
because some people don't even know what we do at the health department. You'd be surprised. They think that we just do STD screening and flu shots, and it's way more than that. Way. It's changed dramatically in the last year. We're billing insurance now, which we didn't, which is
I didn't
bringing
know that.
It's huge. We're bringing revenues in just from May till now of almost $1 million in claims for the whole state. So we were shooting ourselves in the foot not getting on board with insurance. Yes, because we were going broke, not just giving stuff away for free, giving services away for free.
It says, describe how the advanced practice nurse functions using the core competencies such as direct care, consultation, collaboration, research skills, clinical and professional leadership, expert coaching, and advice, teaching, ethical decision making. Okay, well, I don't really know how to. Okay, direct care. So you're independent, usually on a daily basis, but part of a team.
Mm-hmm.
Consultations you refer out.
Mm-hmm.
What typical things do you refer out for?
If it's something that is beyond my scope of practice, especially at the health department, we're very limited to, like, we don't do in-house lab as far as like CBCs, thyroid screenings. If I feel like that they need that, I can order it and interpret it, but I'm not going to treat it there. I'm going to send them to their PCP. Main reason it's the insurance thing, because they won't. It's really the way
reimbursement. You're taking that liability.
Right, that and it's just the way they don't know how to bill yet there. It's really confusing, and so they're confused about that. So it's easier just to send them to a PCP. If they're having dysfunctional uterine bleeding, if they're having infertility issues, breast cancer stuff. I've had a lot of young girls come through there, and I send them for mammo, and then I follow up, make sure they get the care, where they need to go, those kind of things. Anything that's specialty related, I do. We do treat, all kinds of treatment for female issues that are going on, especially problems with periods, What else?
Y'all do,
I
y'all do
do.
like early childhood teaching and y'all do a lot of things like that, well, programs.
Yes, we have a lot of good referrals. A lot of girls that'll come in and they don't have any support systems. We work real close with all the mental health agencies, and we've started new depression screenings on everybody, especially postpartum, and we've caught a bunch of that. So I collaborate with all the different things like Children First. We have Bright Beginnings, Sooner Start for children that are born with disabilities. So if we have a girl that has a baby with a disability, we've got all that right there, speech therapy, nutrition. So if there's someone who wants to lose weight or having problems with anorexia or something, they're right there. And so we've got a lot of good.
Okay. Let's talk about, are you involved in any kind of research at all with the state?
Yes, we do have projects going on right now. Like right now, we're doing a real big one on the implants that I'm putting in. They take all the data, and we have all the documentation sheets that we have to turn in. How long that they kept their implant in, what problems they're having, whether it's anemia, whether it's a psychosis kind of
You're talking
thing.
about the IUD?
The implant, the next one on.
Okay.
Yeah, and right now we're on a pilot trial for that. We're just because we're trying to get more funding for it.
Okay.
They're very expensive, and so we did one with NuvaRings, side effects, things like that. They do a lot of research on that. So
I didn't know that they did all that.
I didn't either. I didn't know when I was having to, but yeah, like everything has a document that goes with it. We're way behind times on technology there. That's one of the drawbacks working with the state. Everything is paper charting. It's this big. You got a huge chart you got to go through. Nothing's EMR right now. We do have a lot of computer system that we enter all of our data, but not.
But it's almost like doing it twice.
But
sometimes.
not the actual documentation that you see the patient every day. So I don't like that at all. I love EMR.
To click and go.